Hi, it's Martin from In the Mess. Today we're going to talk about abdominal aortic aneurysms. Abdominal aortic aneurysms, also known as AAAs, are quite a common finding. They can be dangerous if they get too big because they're at risk of rupture. This is an emergency. So if you have someone who has a known aneurysm, or you suspect they have an aneurysm and they come with severe abdominal pain, it's important to phone early and refer to vascular. Obviously, you should take a history and do an examination first, but if you're concerned and the patient is hemodynamically unstable, get the vascular team moving and they can come and help you assess the patient. Given the urgency of the situation and the need to get to theatre without delay, a full clerking isn't appropriate here. Start with an ample history and relay this to the anaesthetic team. They'll then guide you for any further information that they want you to gather. But speed is key here. Details can come later. You need large bore access in both antecubital fossas. Nothing less than a 16 gauge will do in this situation. Don't necessarily transfuse straight away, but you need to have that access, so if you need to transfuse, you can do. We allow the patients to have permissive hypotension. This is debated whether or not it makes any difference, but if the patient is perfusing their brain and they have a systolic blood pressure of over 80, we wouldn't recommend transfusing them blood or giving them IV fluids at this point. This is because the aneurysm is tamponaded, and if you fill the patient full of fluids and increase their blood pressure, this tamponade can burst and the patient can bleed out. If the patient comes into the A&E department from the community with severe abdominal pain and hemodynamic instability, quite often they will do a FAST scan, which is a focused abdominal ultrasound scan in the department to see if there's any fluid and see whether or not they can see an abdominal aortic aneurysm. If they can or if they can't, it's still really worthwhile getting a CT angiogram straight away. If you phone the radiologist, they'll stop everything else and prioritise this scan, because this patient, if they're going to survive, needs to go to theatre. So what can you do in A&E? Bloods, including group and save, cross match, at least 8 units of blood, and if they're hemodynamically unstable, phone the blood bank and activate the major hemorrhage protocol. One of the strange things you may notice on your first VBG that you do in the emergency department is that the hemoglobin is normal. I've been telling you these patients are bleeding out into their abdomen, and there's a reason behind this. After acute bleeding, the hemoglobin may not drop for some time, particularly if you haven't adequately fluid resuscitated the patient. Your patient might be hypovolemic with a normal hemoglobin because they haven't been fluid resuscitated. You measure the concentration of hemoglobin in the sample you have, not the total body hemoglobin. So the HB doesn't drop until you've fluid resuscitated and filled the patient up. Then you'll find that the patient actually has a hemoglobin of 40 when you thought it was 80. So it's essential that you do a full fluid review of these patients to make sure that they have been fluid resuscitated and you're not getting a falsely elevated HB. So, patient's had his CT scan. I say he because men are much more at risk of aneurysms than women. You phone the anaesthetist, they're in the CT scanner with you. You then go straight to theatre from there. Centres vary in their approach to the emergency ruptured aneurysm. Some places will offer an emergency endovascular repair through an EVAR, but most centres will still prefer to do an emergency open repair. A consequence of an emergency AAA repair is a revascularization injury. This can occur at the time of the operation or several hours later in critical care. If you're one of the doctors working in the critical care environment, you need to be aware of this and how to manage it. So one of the things we look for is derangement of U's knees, an acute kidney injury, and liver failure. You should be doing regular blood tests on these patients, probably every 12 hours. You should also be looking at the legs, checking for their perfusion, examining pulses, listening for Doppler signals, and making sure that the feet are warm and well perfused. Sometimes clot can form during the operation and be thrown off to the legs, so you need to be aware that these patients can get an acute limb ischemia as well. It's important that you recognise and escalate these issues early, because these patients may require reoperation or further organ support from the critical care team until the revascularization injury has been overcome and the toxic products have been excreted. Another important thing to recognise post-operatively is fluid balance. These patients have had massive fluid shifts and their hemoglobin will be very labile. This is because fluids will be shifting between compartments. Regular ABGs should be done to keep an eye on the hemoglobin, and stringent fluid balance charts should be kept. You should be keeping an eye on these to make sure that your patients aren't becoming overloaded, but they have adequate volume resuscitation. And that's what you've got to be mindful of when you're managing any acute major hemorrhage. AAAs are diagnosed in several ways. First of all men over 65 attend a one-off screening program, which is an ultrasound scan of their abdomen to look at the size of the aorta. If this is greater than 3.5 centimetres, they enter into a continued surveillance plan until the aneurysm reaches 5.5 centimetres. This is where they get referred on for discussion with a vascular surgeon. This is because at 5.5 centimetres, the UK small aneurysm trial shows that there may be a benefit to treating the aneurysm rather than leaving it be. If the patient is seen by the vascular surgeons and is deemed appropriate for surgery at that time at 5.5 centimetres, we then send them on to our anaesthetic colleagues, who will do an anaesthetic pre-assessment. When fixing aneurysms, you have two main options of how they can be fixed. Just to clarify, we're talking about simple aneurysms which are below the level of the renal arteries here. The first option is the traditional open approach via a laparotomy, where we cut down to the aorta and replace the aneurysmal section with a tube graft or a bifurcated graft into both of the iliac arteries. We then sew the aneurysm sac back over the exposed graft and allow blood flow to go back through. This excludes the aneurysm and stops the risk of rupture. The other way that we can treat aneurysms is using an endovascular route. This is where we do percutaneous access, which is where we puncture the femoral arteries in the groin and put stents up. We expand these stents within the artery and they're covered with a synthetic lining, which again excludes the aneurysm and prevents the risk of rupture. The problem with EVARs is that they can have problems, they can have leaks. So those are the main two ways of fixing an aneurysm. It's important to have a discussion with your patients about which of these they would prefer, as open repair is a bigger operation with higher risks but offers better longevity of repair, whereas an EVAR is an operation that you'll be out within 2 or 3 days from, but can have complications further down the line, and they do have a lifespan, so we'll start to have complications 10, 15, 20 years down the line. So they're good for the older population who may not survive that long. Don't forget to like and subscribe.